Be good. Okay, great. And I can send you just the YouTube link to the recording that you're able to access. I'll probably just set it to private, so you'll need the link to look at it, but otherwise you'll be able to view it afterwards.
Perfect. Thanks, Jamie.
Yeah, no problem. So thank you, yeah, for reaching out. I know I went back and looked over the email that you had sent previously, and I know that you said you were interested or that you'd been using, I think, the small area estimate or the custom area tool on Community Commons and now on the CARES Engagement Network. And I think I remember you guys also maybe mentioning some data upload, but I would love to just take a few minutes to kind of learn a little bit about your roles at Trinity and kind of what it is that you guys are looking for. And then I can kind of demonstrate some of the systems that we have, and we can talk about whether we can meet your needs or not.
Excellent. Sounds good. Okay, so Rachel and I are both in our system office at Trinity Health, and our role is community benefit compliance, and we work with all of our different ministries and their community health needs assessments, and so they're done locally. So we have 47, 49 different hospitals that do a needs assessment, and we just kind of review to make sure that they're compliant. And so now going forward, though, we really want to standardize what kind of indicators all of our ministries are looking at. We want to really make sure that they're focusing on social determinants of health, and really including that as part of their analysis. So what we were hoping to be able to get some kind of an online interactive type database where they could go in and they could have some standard reports set up. And so I know that, like, in each of our ministries, some of their service areas are really quite large, and we'd like to be able to see the different ranges in their service areas for the different data. Another need of ours is we would love, being in system office, to be able to look across all of our ministries, and we're across the United States. We'd like to be able to look at our ministries, compare them to each other, and to be able to pull indicators here at the system level.
Great.
Do you want to add anything to that, Rachel?
No, I think that just, I guess the only thing I would add is that our ministries did use Community Commons for their CHNAs prior, because we liked the common indicators that were available and the fact that they were all looking at the same thing across the board, and we were ensuring that they were looking at the social determinants of health that way.
One of the other things I was going to add is we want our ministries to start using this data on a regular basis. So we don't want them to just run it once every 3 years for their CHNA and not look at it again. So we thought that if there was some kind of a tool set up so that they're not having to go in and put in all their zip codes every time and such a manual process, that they could have something that they could share with even people in their hospital or that they're collaborating with, and pull indicator reports on a more regular basis.
Yeah, well, I think that you come to the right place, and you're speaking the right language to me. So everything that I had planned to demonstrate today then is right in line. I just wanted to make sure, that we were all kind of on the same page there. So just to give you guys a little bit of background, as you probably have gleaned a little bit from the changes on Community Commons. So the Community Commons site is shifting away from the maps and reports functionality and becoming sort of more of an aggregator function in terms of, what are all of the different types of data systems that are available, and what are all of kind of those best practice resources and related to, CHNAs and CHAs and CHIPs and, public health accreditation and all those kinds of things. So they're really looking to become more of a resource aggregator function. And so CARES, we're the Center for Applied Research and Engagement Systems. We're on the campus of University of Missouri and part of our extension program here. But we've been providing the technology and data to Community Commons since it launched back in 2011. And so we recognized that, there were a lot of hubs and a lot of custom tools that we had built for Community Commons that hospitals and community groups and just people in general that are doing community health work had kind of come to rely on. And so we decided to launch earlier this year the CARES Engagement Network to host those tools and data. And so that's what you're seeing on my screen now. So this will probably look very familiar in terms of, the functionality and the data that are housed here, just because we have just basically duplicated, although updated, but duplicated the systems that we previously housed on Community Commons over here on the CARES Engagement Network. We did take some time to do some improvements, and hopefully you'll agree with us that they have made the system better. So I can walk through our reports and such, but really just wanted to let you know that the make a map function is still here, and we still have roughly around 20,000 data layers available in our mapping system. And then this build a report is our public CHNA that we've made available. And so we did cull our list a little bit when it came to switching from Community Commons over to the CARES Engagement Network. And we did that for a variety of reasons. And several of the data sets that we were using previously. So we've had about 137 indicators in our public CHNA on Community Commons. Several of them were getting pretty out of date. And so we decided to kind of remove them from the report. While we still have them available, we just wanted to, kind of take them out of the public sphere just because they are showing some age on them. Some of the others were leaning more towards more highly analyzed or proprietary data that we had also shared out publicly. And unfortunately, we know that there have been lots of consultants and other folks who have used our systems to make money. And so we're trying to still provide a public good, but maybe curb some of that activity a little bit. So but the bigger thing that we did really with the engagement network is we did transfer over all of the hubs that were in Community Commons over to the engagement network. So you can see here that you can visit all of the different hubs that are available. And these are really, I think this is probably the best solution to what you guys are looking for, because we consider, our public tools to be great resources, but like you've mentioned here, you have 49 or 47 hospitals that have, custom service areas. And so having to go in and select those at a zip code level or draw those custom geographies every time in the public tool just isn't sustainable, or it doesn't make it very efficient, right? And so,
yep, exactly.
So that's some of the work that we have done. I've got a couple of health systems pulled up here, and I'll show you their hubs. So we actually have two Adventist groups that we're working with. We have an Ozarks Health Commission and then Providence Health Services. We also work pretty closely with KP. We've had multiple systems for them in the past, and right now we are still providing them data for their CHNA. So lots of work with health systems. And the exciting part there for you to think about too is that what we provide publicly is just a very small subset of the actual data that we have in our engine. And so currently we do have about 235 individual indicators to choose from for groups that engage with us in a hub environment. So I can send you that full list after the call today, just so you can kind of see what that looks like. The other opportunity is that we do work with a lot of groups to pull in local or state level data as well. So, we recognize that there are data sources at a state level. So maybe, your state Department of Public Health or Health and Human Services or something like that, that might have some indicators that you would be interested in incorporating into a reporting environment, again, so you can reach that standardization that you're looking to reach. but also kind of making it more robust and more localized, right? So that's something that we do pretty regularly, is work with other data sources on a state level. And we've started to, I would say, we're not fully committed, but we've dabbled in pulling in also aggregated or de-identified EHR data as well. So I don't know if you guys have or are interested in anything along those lines, but that's something that we've been exploring with several groups, just how we can take some of the hospital level data that are collected through EMRs or EHRs, de-identify and aggregate it, and then have that also available as some local level data that could either be incorporated into a CHNA or into a mapping system. So
that's great. I think that's something that we're looking to do in the near future, to be able to do that too. So
great. Yeah. I mean, there's just so much opportunity there, right? To look at the broader social determinants of health, and then also look at, prevalence among the people that you're actually serving. We know that it can be really powerful. So like I said, we're exploring some ways to do that well. So anyway, so this is, just kind of a list of the hubs that we currently have on the engagement network. I was just going to show you a couple that we have here. So this is one of our Adventist sites. So we have Adventist, what we consider East and West. So there's like a Florida group, and then there's a California group. So this is the California group. But what you can see here is they've got just a pretty simple landing page. And with our hubs, we do have a lot of flexibility in terms of customization. So typically when we enter into a contract with someone to build a hub, we set up about 2 1-hour design sessions, and just to talk through kind of what are your brand standards, what kind of information do you want to make sure is included on the home page, or some people are real picky about what shows up in the footer. If you need to say, have sponsors or, logos or whatever. So we're happy to work through those kinds of things with you. And then really just kind of talk through what are the navigation items. So this is a pretty standard kind of baseline hub where they just have a pretty simple home page. And then we also have this link to their community health needs assessment. And so I think this is what's going to be great for you guys, knowing that you have so many hospitals in the service areas. So you can see here that this is the first step in developing their community health needs assessment, is the report area selection. So this should all kind of look familiar from Community Commons, but as I mentioned, we updated the interface and hopefully made it a little bit more streamlined. So as you click into there, I clicked into Central California, it displays here, and then you can see all of the different service areas that they have here. And so the way that we've built out these service areas, because they are custom, is really just based on mostly on zip codes. I think there's a few within Providence that we've done a little bit even more custom geography where their service area didn't align with a specific zip code. So we were able to kind of do a little bit of cutting, for them. But typically, yeah, I mean, it's best if you do have the zip codes that are associated with your service area, so we can build from those. So you can select any of these. You can also you can select one or more. So that's the other good part for you. I know you had talked about kind of at a more system level to see across all your hospitals. So you could potentially select all service areas, or we have this hospital region. So you could select an entire region and pull a report for that entire region. So those are all predefined. And then we also have the county here. So if you wanted to pull your CHNA, for example, for just a subset of counties. If you've got folks that are doing some targeted community benefit work, for example, within a county, they could pull a CHNA for just one specific county, and you can see. So that's kind of nice that you've got that flexibility in terms of selecting a service area. So I'm going to go ahead and just select a couple here. Then we get into the data indicator selection. So this is all customizable. So as I mentioned, we have a list of about 235 indicators that you can select from. And so, just leaning back to the, talking about standardization, this would really help you guys get to that, right? So everybody has to have at least these indicators included in their CHNA. If hospitals wanted to include more, obviously, that's up to you guys. They could or couldn't or whatever, but this will give you kind of a baseline to work from. And you can see here that this Adventist group actually has quite a few. I don't know their exact number, but it's probably close to 100 here. But it does cover a nice variety. You can see just demographic information. And the important thing to note about demographics, and you guys have used the Commons before, so you know that we do provide population group breakouts when available. So things like race, ethnicity, age, and gender, which we know is also important in the CHNA process. And that goes for all indicators that we have. If we do have those breakouts available, we always try to make them, publish them as part of the report. So you can see here all the different social and economic factors, physical environment, clinical care, health behaviors, and health outcomes. So the indicator selection themselves is customizable by you all. And then also we can customize these data categories. So if you guys had specific a specific taxonomy that you wanted your hospitals to work from, this is just kind of a more standard taxonomy that we use across a lot of our reports, but it is customizable if you're interested. So I'll go ahead and just select some indicators here. Did you have a question?
No, I was just going to say,
okay.
We're both smiling.
That's great to hear. I guess one thing I didn't mention too, we do have these little I buttons next to each, and that does provide folks with some data attributes, and then link back to the original source too. So if people were more, I imagine the people that you work with are a little bit more savvy and might be interested in methodology and stuff, so you can get back to the original source to learn those types of things. So the other big change that we've made, or significant change, I guess, that we've made from the common system to the engagement network is, so the comprehensive report is basically what you're used to getting, but we have also implemented these other supplemental reports in a sense. So we have a quick facts report, which is just a series of data tables for the indicators that you've selected. So and then we also have this export data to Excel. And this was really based on a lot of the work that we've done with hospital systems, knowing that sometimes they want to do additional analysis or pull that into an Excel file. And so all those indicators and all that information for the report area that you've selected can be pulled into an Excel file if that's something that is of interest to you guys. And then we've also broken out the source and methodology. In the common system, when you pulled a report, that source and methodology was sort of part of every indicator or part of every page of indicators, and it made the report hundreds of pages long. And so we've broken that out into more of an appendix, so it's still available, but it hopefully helps clean up the output of the report a little bit more. So here I'll go ahead and just run this, and you can see that the layout is pretty similar to what it used to be. You can see your location here, talks a STEM sentence that talks a little bit about social and economic factors. And the reason I bring this up is because this is all customizable as well. So if you wanted to include specific, if you wanted to write some of the STEM sentences or put it in more of a context of Trinity Health and your mission or something like that, this is all customizable here. And then, you get into your actual indicators. So this is an example here for children eligible for free and reduced price lunch. So you have your STEM sentence, you've got your data table. So this report location is the aggregate for the 2 service areas that I've selected. And then these are the individual counties that are included in those service areas. So you can do a nice kind of county comparison if you're interested, or see kind of who the outlier is, or something along those lines. And then we do have benchmarking information for the state and the rest of the nation. Benchmarking is also something that is customizable. So we work with, as I mentioned, like KP, they had like Healthy People 2020 benchmarks that they wanted us to use, and feel like there was something else. But anyway, if you guys do have other benchmarks or unique benchmarks that you want us to include here, we could do that as well. So then there's, go ahead.
Can I ask you a question about that?
Yeah.
So, yes, so I was wondering, like if we had Trinity Health benchmarks, so you could add that to the.
Yes. Mm-hmm.
Okay, and then the other question, and maybe you'll get to this, but like I love that little graph next to the table. Would things like that be able to, would we be able to create reports that just include graphs, or can they be copied into a published CHNA?
Yeah, so I'm going to I think I'm going to try to answer your question. Let me know if it doesn't answer your question. So you can download this as a PDF. So you can take these and screenshot them and pull them into another document if you want to. We also, for our, we work with a lot of community action agency groups, like state level, and they do CNAs, which is sort of like CHNAs. But anyway, they have a export to Word option. So we do export like the data tables and the dials and the maps and charts and graphs and stuff into Word documents. So then they're editable. Basically, you can edit around them, edit around these elements. So those are possibilities as well. So I'm just, does that answer your question?
Yes, absolutely. Yep.
Okay, great.
So I have one question about the report location. It's great that we can look at the aggregate of all of the zip codes that we've chosen for our reporting. Is there a way that we can flesh that out and see, sometimes we want to go a little bit deeper and look at the zip codes themselves and what each, because there might be one that's doing really poorly and one that's doing really well, and we want to focus on the community that's not.
So you're thinking like that zip code, or can we drill down on that zip code, and especially if the information is by census tract, if we could see.
Even just drill down into the report location to see the different zip codes, because right now it's aggregate.
Gotcha.
Mm-hmm. Yeah, so I will say I think it's possible for most indicators. So not, as you probably know, not all indicators are available at either zip code or census tract level. And so that's why we typically report out at a county level. Let me talk with one of our data analysts here, and she'll be able to answer that question probably more fully than I will, and I can have her email you guys about whether we can actually display those values or not. I think for the ACS data that is available at a zip code level, that shouldn't be too much of a problem. The values, or the indicators that are only available at a county level, we do use a small area estimate methodology sometimes to calculate the zip code level values, but there's margins of error that go along with that. Yeah, I'll take that question back to her and have her respond to you guys and let you know what is possible or what's recommended.
Okay, thank you.
Yeah, no problem. So yeah, inset maps here, and then of course, anytime we can show data over time, trends over time, we do so in both table format and then in a chart like this. So you can see that this, again, still looks pretty similar to what we had on the Commons. We have changed the navigation a little bit so you can jump between indicators a little bit easier. So I could choose any of these others, and you can see that the report just kind of automatically jumps down to where I'm going and what I'm interested in. So We do have, as mentioned, the download a PDF option, ability to share it via email, print it or export it. And then, like I said, in other systems, we do have that capability to export to Word as well. So we could turn that on for you guys. So that's an example of newer CHNA. We do have also a what's new section that we try to maintain, or that we do maintain, not try to, for all of our systems that tell you indicator corrections or data updates. We know that this is often important for you guys to know when data have been updated, and so you can search this if you're looking for something in particular. We also have built in a GIS system, and so this gives you access to our larger data engine with our 20,000 plus layers here. So this really speaks to folks, with the CHNA, like you're saying, it's like, when it's due, that's when they pull the report. And we do a lot of training on sort of use cases where folks can use the CHNA report for other types of community level work or interventions. And so that's something that we can talk more about. But we find a lot of folks use this map room more frequently outside of the CHNA cycle, just because there is so much data included in here, and it can be, pretty fun to kind of play around with different indicators and, zoom to different locations. And you guys are in Michigan, aren't you?
Yes, we are. Mm-hmm.
Yeah. So being able to look at, you can put lots of different indicators on a map and kind of talk about what that means and what it looks like in your community and those kinds of things. So we do have some more advanced tools within the map room here. So you can do queries and multi-criteria queries. So that's often helpful. You can select data and pull Excel files of the data that you're interested in, those types of things. And so this could be something with some training as a way to encourage folks to be using this data and assessing their community outside of that CHNA cycle a little bit more. We have a support section. So theirs right now is pretty limited. It's just a CHNA user guide. We're working on a bunch of videos right now for user support. So that's something that we offer as part of your contract. Is typically we'll create a user guide and a couple video series that walk through the CHNA and the map room. And then we do offer 2 1-hour either webinars or if you want an in-person training, we can do 1 in-person training for your folks through a contract year. And that can be increased if you're interested in more training, but kind of baseline is that 2 1-hour webinars throughout the year. And so this is a system, you can see here the last one is log out, that is password protected, or you have to have an account. We do have the flexibility in terms of user roles and security to either have the site be public or to put login. So folks that land here will still see your homepage, but they wouldn't be able to access the CHNA and actually create a report until they had logged in. So I'll stop there. I know we're at the top of the hour. I have extra time if you guys have more time, or we can wrap it up.
Yeah, we have extra time. Yeah. That'd be great. Thank you.
Okay. So the other systems I have pulled up here, pretty much they mirror this one. I can show you this Ozarks Health Commission. They have a health assessment report. Theirs is set up just a little bit differently, where they have about 51 counties that they have sort of in a region. So you can pull the same kind of report. The data indicators look a little bit different than what you saw in the Adventist report, but it's going to be basically the same output. The other thing that they've done that has been pretty cool and other groups have liked to see is they have initiated sort of a CHIP process, or community health improvement plan. So we developed a system for them to track the progress of some of these indicators or the objectives. So you can see here they go in and they have, these different objectives that they're trying to meet. And so you can see here, for example, that they've put in some quarterly updates of the things that they're working through. So that's just kind of an add-on, you know, something that you may or may not be interested in, but it is kind of a nice way for them to have a more public facing or transparent way to say these are the objectives that we're trying to meet, and these are the steps that we've taken to do so. So that's one. And then Providence, I think, is pretty much exactly the same. You can see here that we've done service areas for them, and the report output is going to look pretty much the same. I don't think they have any unique indicators, but yeah, they're all pretty much the same. So I'll stop there. I've talked a lot. I just want to give you guys an opportunity to ask any questions, or, you know, if you want me to demonstrate anything else, I'm happy to do so.
So my question is, so you said, you know, the outward facing. So is all of this publicly available once it's on here?
So like I said, some systems are publicly available. So for example, this Ozarks Health Commission site, there's no login associated with it. So
Gotcha. Okay.
yeah, so you could go in, you as, you know, just a random person, and you could create a report from their indicators or use their map room or look at their chip, right? But then Adventist, on the other hand, is that you could see their homepage, but if you were to click on Community Health Needs Assessment, it would prompt you to log in before you could create
Gotcha.
a report.
Okay. Let's see, we had a list of things here. Community assets, there's the ability to map those, is that correct?
Yes. So that is another functionality that we definitely offer, is data upload. And so we have, we're actually revamping that tool right now. So, but yes, basically if you have, you know, locations of FQHCs or community health centers or whatever it is that you're looking to map, if it's point level or even polygon level, the data upload tool allows you to do that within the map room. We don't have the functionality right now to upload that like into a reporting system. We can obviously do that on the back end. We could include that in the report, but we don't kind of have a UAD tool like we do for the map room. So that's something that we've always kind of talked about. We just haven't had the R&D time to develop it.
I think a lot of the assets are included in those 20,000 indicators for your map room, though, aren't they?
Yeah, so we have a ton of stuff already. So, you know, like public schools and
like schools, churches, hospitals.
Yep. We've got lots of hospitals of all different kinds. You can, yeah, all the different listings there. So yeah, a lot of them might already be included.
Okay.
Cool. Yeah, I think these are all, the questions have already been answered. How about the frequency that your data is updated and refreshed?
Yeah, so we have a team of about 4 people who that's all they do is kind of just keep the data in our system up to date. And so we have flags that go off basically every day, depending on, you know, what is made available and ready to be updated. I'll give you an example of like the ACS, you know, they typically release raw files. That's the biggest data set that we incorporate, and it's a lot of our CHNA. They release those raw files sometime in like November, December period. And that in particular takes us about 2 months to integrate. So we usually say beginning of February is when that ACS data will update each year. That's kind of the biggest one that people always ask about. But these other ones you can see here, you know, you can see that this is like a quarterly release. So we'll update it as often as it's available to update. So it really depends on the raw data release cycles for each of those things. But it's always being updated. And the other good thing about the CHNA is that basically if you make a report on Monday and you come back on Friday, and for example, we've updated some unemployment data because, BLS updates unemployment data on a monthly basis, right? The report that you make on Friday is going to have that updated data in it. It's not something that you have to select manually or worry about. We just always make the most recent data available within our reporting environments.
Cool. All right. Well, so I guess the next big question we have is like pricing.
Yeah, right. This is the part of the conversation that I'm like, okay, sounds good. See you. No.
That's why I was talking to you.
I know. I really like the demo part, not pricing, but so we have so Basic Hub, like the Adventist Health Hub. So this one, really our pricing would start somewhere around $12,000 to $15,000, and so that's basically for indicators from that list of 235. So you could pull any of those that you were interested in. We'd give you access to a map room. We would, like I said, do some design sessions with you to set up the hub, put together some support materials and do trainings for you, those types of things. So that's all included in year one. So so that $12,000 to $15,000 is really baseline. If you wanted to go outside of that, so I think that I know that there would be a small additional cost, so somewhere probably around $2,500 for us to do the custom service areas for you. So that would be a little bit of an additional cost to do the calculations for those service areas. So you're looking at just a little bit more than, like I said, somewhere between 12 and 15 there. And then if there's any additional customization, so we have some hubs like Colorado Food Policy Network, which they asked for a lot of, you can see here, there's a lot more to their design, and we built them sort of this more flexible kind of leaflet map. So we have a lot of extras that we could add on, but I guess I'll stop here and say base price somewhere between $12,000 and $15,000 for year one. And then we do just may have a maintenance cost after the first year. If you don't have any big changes to your site, usually you're looking at a maintenance cost somewhere around $9,000 or $10,000 for subsequent years.
All right. What about number of users? Is there a user per user fee for logins?
We have no limits, no.
So, as we mentioned that, we have, I'll say 59 hospitals, with extensive service areas. So to set up the custom service areas, because we've, it's quite large.
Yeah.
Would that fall into still that 12 to 15,000 range? I know we're just talking ballparks right now, but just to have an idea.
Yeah, so that's what I was thinking, like if to do some of the custom service areas, it would probably be an additional fee, but it would only be an additional fee for the first year, because it would, once we have those service areas set up, it's a lot easier to do tweaks to them. So if for some reason in a year one of them changed or something, we could tweak it without, adding any cost or anything. So I would say for 50 or 50 plus service areas, I would probably say, conservatively, you're probably looking somewhere between $2,500 and $5,000 to do those additional custom service areas on top of the base price of the hub.
Sure.
So I'll get with Angela and check with her on that too, just to see kind of, because I think like this Adventist group, they have a ton as well, and I can look at their contract and kind of see what it ended up being for them, and that would probably be a better representation, but I'm guessing somewhere around there. So you're probably.
So if it's helpful, I don't mind sending you a list of all of our hospitals with the zip code, so you can have an idea of what we're looking at.
Yeah, that would be helpful. And if you already have those I mean, it sounds like you guys already have that list, which does a lot of the, that does a lot of the work for us too, which definitely lowers transaction costs.
Okay, yeah, and we do.
Good.
So I mean, this is great. I mean, honestly, what you showed us is kind of exactly what we were envisioning, and especially some of the things that I liked they could do the CHNA reports with the big data sets, and then we're talking about having somewhere from 12 to 25 indicators that we want to look at on a regular basis at system office. So doing that kind of snapshot type report too that we could look at across our system is intriguing to me.
Yeah, and we can set that up in to sort of feel seamless, right? So if you wanted, here you see like hospital service area, hospital region, and then we could do, system wide or hospital system level or something, and it could pull just a subset of the broader CHNA indicators too. So that wouldn't that's not really a lot of lift on our end to do something like that.
Okay.
Because it's, like I said, it's a subset of data that we already have. It would just be doing the aggregate for it, which once you have all those service areas, it's, I won't say easy to aggregate, but it's a lot easier to aggregate, right?
Right. So if we were to add hospital patient data, I definitely see us going along those lines eventually, especially as we look at readmission, which I think I saw that on Adventist on their list. They had readmission rate. To upload data, does it all go through your team, or if we had people trained here, is there anything that we would be able to upload our own type data?
Yeah, so that is a little bit separate of a conversation. So we have a couple of ways that we can look at it. So one would be, you guys send us data, which would be a lower transaction cost on our end, but it might be a lot of work on your end, right? Maybe you have someone to do that, but they could send it to us already de-identified and aggregated and cleaned, right? So we can just insert it in the system. So that's one option. And that should meet, because the other big factor in that is the HIPAA compliance, right? So
absolutely.
Because we don't currently have HIPAA compliant servers. So that leads us to the next option, which would be that we have some sort of shared database, which we've done with other groups, like an AWS and an Amazon Web Services or something like that, that would be HIPAA compliant, where we could make a connection. So you guys would upload the data to that database or web services service, and then we would extract it from there. So that would be the second kind of option. And then the third option is, depending on what system you guys use to collect and house that data, we could also look into like an API, which would just be a direct connection between our database and your database, and it would be an automatic kind of just pull, and we would pull it nightly or monthly or quarterly or whatever kind of schedule. And then that would be probably, the setup would be a higher transaction cost to get our systems to talk to one another. But once that's established, then that would be a pretty low transaction cost for everyone, right? Because there wouldn't necessarily be a person that would have to be involved in that. So yeah,
I think for our purposes today, that's all we really need to know right now.
yeah, right.
I'm thinking, I'm not a data person. I'm like, oh, okay. Our data people, so what we're doing right now is we're fast finding.